Angela Moturi is an assistant research officer at the KEMRI Wellcome Trust Research Program. She joins us now because we want to talk about the importance of population health research. Yes? Angela, good morning.
Good morning.
Good to have you on the show.
Thank you for having me.
Welcome to the hot seat of the Situation Room.
Well, it's a bit cold. So
it's a bit cold.
It's all right, yeah.
The person who was seated there before you was sucked up all the heat. City.
Yes.
Why don't you welcome Angela with the day's proverb?
Yes, our proverbs for the whole of this week are from the Republic of Congo. Okay? Not DRC.
The Republic of Congo.
Congo Brazzaville, as otherwise known. A bald-headed man will not grow hair by getting excited.
Bald-headed man.
I thought bald men were getting a better rep.
They do.
That's a conversation for another proverb.
Yes, and remember, it's specific hair, okay? There may be other ways of getting hair to grow on their bald head, but getting excited is not it.
Not one of them.
Yes, it's not it.
Right. But I think I look at it from the perspective of certain aspects, like we need to accept. If you're bald, you're bald. And I think you maybe get a hat if you're not okay with it. But the situations we can't fix, no matter what happens.
And even with the bald, you can still make it happen.
Yeah, it's actually quite a good look.
You see how we have...
Okay. Okay. So you can be excited because you have the bald head.
You see
Yes.
now?
Yes.
It's a type for certain people. So it works.
Angela, what is population health research?
All right. So allow me to start by just giving a bit of context.
Yes.
Whenever the topic of health comes up, particularly in these forums, the focus is on specific diseases and understanding how individual level, at an individual level, people can improve their own health. And we've had messaging on how you can improve your diet and your lifestyle. But now there's increasing recognition of the broader influences that affect health. And so when I talk about broader influences, I'm talking about socioeconomic factors, environments in which people live and work, as well as how policy impacts how healthcare is provided. And all of these work together to affect the outcomes of different groups of people. And so it's from that understanding that population health research grew to be an important area. And so our work at the program is looking at the distribution of different diseases and health outcomes and understanding in different contexts how all these broader factors influence health, and that informs planning at both county and subnational level.
So what factors are these that you look at?
So as I mentioned before.
So you'll begin with population.
Yes, so first population. We need to understand different groups of people have various needs, right? What you would require from the health system is not what I will require from the health system. So we first need to understand who you're serving and what kind of diseases they are at risk of, what conditions they might need help with, what kind of asks they have of the health system. So you need to be able to know what communities am I trying to provide health care for, and what kind of healthcare services are needed for those people. So now you know who you want to provide for. How does the broader system either improve or put at risk the health of these people? So if you're living in an urban area, the consideration we have for your health is different from someone in a rural area, because you have more exposures to certain pollution, and in a rural area you might not have that risk. So you need to take into consideration the various contexts.
Okay.
So, yeah.
Okay, so then, if I just want to pull it apart a little bit. So this could also help for when we say how a centered body, Ministry of Health, for example, would then be able to say, this is how I'm going to plan around my finances, because I know that in a certain area, non-communicable diseases are the issue, or in another area, infectious diseases are an issue, or in another area, water issues are an issue. So that will then help me. The research then actually would help in how you then are able to plan for your health finances or resources, as well as kind of equipment you need to be putting in certain hospitals, kind of thing. Am I totally off?
You are right on the money, actually, because the main thing, we're working within constrained resources. So you need to be able to allocate the funds you needed to the areas that are having the most need. So, for example, a lot of our work has focused on malaria. And so we've looked at both the environmental data and data from routine health systems to understand at very fine scales, up to a sub-county level, areas that have high prevalence of malaria. And this allows now also county governments, national malaria control programs to target interventions at very specific populations. And also you know how many of the population are at risk. So you know how much money you will need. And then over time, because we keep giving interventions, we need to know, are they working? Are they making an impact? Is our money being spent in the right places, or should we perhaps change strategy? And so our research work also looks at how disease changes over time, how it affects different populations, how the efforts that we have made so far have actually worked to improve the health of our people. Yeah.
Who uses the research that you come up with across body? Who then picks it up?
Who's our biggest consumer? Actually, it's
client?
the Ministry of Health.
Okay.
So we work with them both in getting data on the health system and what utilization of different services from them. So they help us co-create the research we work, and they're also the consumers. And so a lot of our work goes directly into informing policy, informing strategy for interventions, informing how you will craft the different healthcare system to meet the needs of people and meet people where they are. Yeah.
How then have you seen a direct correlation between the research that you found in terms of whatever issue it could have been, and maybe give examples of that, research that you then have done, results of that research having been then applied, and then the biggest client, Ministry of Health, actually taking that research and then applying it, whether it was then the expenditure of resources or the implementation of particular infrastructure as a result of this
of consuming this research.
This research.
Yes, we've seen a lot of this work because we work with them, we co-create with them. So the process, they ask us, like, we want to do this specific thing. Is this the best way we could carry out this particular task? And so work on malaria and understanding extent and prevalence within different population has been utilized very actively. So there's work we did a little recently, and that work was what informed the distribution of malaria and bed nets across the western counties. And so we always, that work actually, we see it going to into play in different aspects. But also we do some work around routine data systems and how health facilities report back to the ministry and understanding the quality of the data that they're getting. And so that helps ministries to be able to be aware of what kind of data and quality that we have. And this goes back to them. And then they look at health facilities that are probably struggling and how we can improve healthcare systems so that we are able to use our own data to create our own solutions. And so also we've done that kind of work of just comparing different systems. And we did this for health facility lists in Kenya. If you're going to plan for health, you need to have an idea of the universe of health facilities that are providing services. And so you have different partners working within the country. And also the ministry has its own listing of these are the facilities we recognize. We know that they provide these given services. But then there was there's always some miscommunication sometimes between the right hand and the left, because there's always one person who has one list that has more facilities compared to another. And so we did work to just harmonize the main listings within the ministry itself, both from, they have a Kenya Master Health Facility list, which is public, and from the reporting platform. So we looked at them together just to see where there are discrepancies and what could be improved to make sure that you're able to link the data from one end to another. And we fed this back directly into the ministry. And because we continue to use this data from health facilities, we have seen the changes being effected. And so we are able to, it's actually a good place to be because we are able to see the action as soon as we give them the results. Or sometimes a little later, but they do actually use
It happens.
Yeah.
Page 3 of the Standard today talks about over-the-counter remedies hurting the fight against STI spread. Okay, and there's this whole new research by Professor Samson Moore, the assistant principal research scientist at the Center for Microbiology Research, that's talking about now spread of supergonorrhea and superchlamydia. And it's looking at how people have been consuming over-the-counter drugs. Now, do you have research that you've conducted on, number one, the people's population's health-seeking behavior, and then maybe layered with that is a prescription behavior by the health professionals, and a dispensing behavior by the pharmacists, and adherence behavior by patients, that they would then have led you to actually predict that this was going to happen?
Well, we have it because that's one of the questions we have, because that's a factor. How people perceive the health system also tells you if they have faith in the health system and will seek out services, and how they seek out services. And when you look at particular, we haven't done any work for STIs and prescription drugs, but I can draw inferences from the work we have done around diagnostic testing, general diagnostic testing. And you find that people either opt to, for example, in malaria endemic areas, people opt to prescribe for themselves that I know I have malaria, I don't need to go to a health facility and get a test. Exactly. Like, I just know. And so that same behavior can be applied to the same. So someone probably has had it before, or feels shame or stigma in presenting to a facility. And so they opt to go direct to chemists and health facility and other dispensers of drugs. But then this goes back to how we develop our health system. We should make it in such a way that people, first of all, are able to access. It might be that they don't know that they can get the service and the test at a given facility close to them. Are they able to afford the services themselves? So it might be cheaper to get the medicine rather than go and get tested. So it speaks to the broader issues around healthcare and healthcare provision, and understanding how people want to seek healthcare and what kind of services they might require.
When you go into these studies, do you then consider patterns that emerge in healthcare seeking behavior?
So yes, because we tend to see, so one of the situations you end up seeing is people bypass. You have a clinic that's right next to you, but you find that people end up going to the level 4, the level 5, and you have those systems being overwhelmed. And so now the question becomes, why are people avoiding the health facilities that are close to them when they offer the same services? And the type of services they're probably seeking from the level 4 is best delivered at the clinic that's next to them. It's probably just a small test that they could have done quickly, rather than go to a higher level facility that should be doing more complicated work. And so that happens across the board. But there's still some uncertainty because people are different and groups are different. So my reason for going all the way to the level 4 might vary from my neighbor. It might be the last time I went to the clinic right next to me, they didn't have drugs, or the nurse talked to me badly and I never want to go again. But for someone else, there's perceived better quality of care. And so we need to understand all these reasons, but there's still work to be done in that area, because that has a very important implication in how people seek health services and how we can better provide healthcare to people.
Does your research not answer those questions?
No, not fully. We can identify patterns in the data, but our work mostly is on the quantitative side, right? So we're looking at how many tests have been done, how many people are getting malaria. But questions around behavior, I think, need both the approaches of social research and understanding of how people view the health system overall. So within the larger program, there are people who are answering some of these questions. But particularly with regard to population health research, we focus right now on just improving the numbers, improving the data, telling counties this is where you are with regards to the services you're providing. You're only reaching this number of people who should be targeted. So right now we're more focused on routine data, improving how you use routine data towards improving your decisions at county and national level.
This data, how do you collect it?
So actually, for a lot of our work, we are not collecting data. As I said, the ministry and our department work in collaboration.
Okay, so who collects the data?
So health facilities. So
okay, and how do they collect this data?
Collect the data? So when you go to a health facility for an outpatient visit, you are recorded. There's a record that we have received this number of people, we have done this number of tests, we have admitted this number of people. And so facilities themselves are supposed to aggregate this data and report it back to the ministry.
Okay.
And so there's a platform for health information system, which is called DHIS2. And so facilities now report back to that platform, and this is the data that now the ministry uses to make decisions about understanding what level of service is being provided.
This platform, you know, when you collect data, usually it involves ticking certain boxes.
Yeah.
Okay? Now, in the boxes that are ticked, do they actually also collect the information as to where this particular patient has come from?
Now, that's actually the crux of the matter. We could understand health-seeking behavior much better if we had that kind of data. We do not collect that kind of data. And just to preface, when you get data from DHIS2, it's not at an individual level. I do know that CT came to this particular facility on a certain day. But we are able from aggregate. If you can get data on, out of the 300 patients we saw today, about 50 of them came from this village, 30 of them came from this village. And that will allow us to understand the patterns so that we can be able to map this out over time and see, are there certain facilities that perhaps people completely choose to ignore for certain reasons or other, or are certain facilities preferred, and why are they preferred?
You know, something even more pertinent, you know, where I'm going with this is, if people prefer to go to certain health facilities, how do we relate this to the sort of conditions or reported reasons why they go there? Case in point, if somebody has an STI, are they likely to go to a clinic nearest to where they live, or are they likely to go to a clinic that is really far away from where they live?
Where they're not known.
That is
where the nurse is not a neighbor.
Where the nurse is not a relative. Okay? So, this information, if it was collected and then collated, of course, and then later analyzed, would it not then provide us with the sort of pertinent, should we say, information that would then give us a far more accurate pointer as to how it is we ought to provide the services that people need at the point they need them, because we will know what is actually needed simply because the individuals who have attended, who have come to health facilities have told us. But if you leave that aside and you talk about populations, then there's a population of people who don't go to health facilities, but as we said, go to pharmacists off the counter. Is it then not possible to have a data collecting process and mechanism in pharmacists? Because some people or many people will go to pharmacists. And even if you don't want, for purpose of confidentiality, you look at the drugs that are procured. Forget the individual. You just look at the data involving medication that people go for regularly or ask for regularly. The anonymity will protect people because it's confidentiality, but it gives you a pointer as to what it is that people desire and what they go for. Would this be a consideration?
Actually, I think that's an important part of what we also try to do within our research. We identify gaps like that because when you're working with just routine data, again, there are people who don't end up in the health facilities. And there are also other different sources of data, such as when we do national level surveys. So you go into different communities, you take different indicators, such as the demographic and health survey that caused quite a stir sometime last year. But it was important because now you get a sense of within the community, for those people we reached by the health facility or those we didn't, what level of coverage are we getting for our services. But I agree, we need to entrench more data collection within the broader health system, not just at health facilities, but across the board of all people who could be providing data.
How do you get people to give you this information? And what are your strategies for collection
of data? All right. So for our work, again, we don't actually do the collection ourselves.
Yes.
So this is within health facilities.
So you just grab what's being grabbed through the health information system.
Yes. But now the health information system is actually very useful because when you have, for example, as I said, the surveys, you don't have a picture of what's happening in your healthcare system more regularly. Yeah. But with routine data, facilities are supposed to report back monthly. And so you're able to see how healthcare utilization changes over time. And also when let's say we implement an intervention for a certain disease, you know the number of cases that were reported positive before. And after the intervention, you can now see, has that trend gone down? And so it's an important source of data, but just for regular use through the health system. But the other sources that we could possibly continue to evolve and include in our analysis.
Is there room to improve that system?
Yes.
Like, just like City was asking, so that it can capture more in-depth data, and who's involved in that chain of decision making to improve the system?
I think that falls within the purview of the Ministry of Health. And when you're talking about room to improve the system, the current
even KEMRI is under the Ministry of Health.
Yes, but the system now is under management of ministry. So what we do, we feed back our findings. So, for example, the work we've done with routine data, it's not a perfect system. And as much as I say every health facility is supposed to report, we found that about 48% of facilities that had a given test made no report of doing that test over a period of 3 years. And that's a significant number. That means you're working with less data than you should.
Yeah.
And then we went further to characterize, so what types of facilities are we not getting reports from, so that we're able to improve their data collection habits and their reporting strategies. And we found that a lot of this is mainly primary care facilities. So your clinics, your dispensaries, and also most of the non-reporting came from the private sector. So you're missing out on two key players, both the primary care facilities where you seek preventive care before things get bad, that you need to take care. So we have a blank on a lot of data from that sector. And also the private sector, which constitutes about 46% of healthcare provision. And so if we're missing data from them, how are we then able to improve and plan for healthcare overall?
Hence the question. So how can we improve on this? Of course, it's the ministry, yes. But what is it that they ought to do to make sure that primary level is actually even more important in terms of collecting information? Because you can then tell what the communities are doing in terms of healthcare seeking behavior, in terms of what kind of issues they're taking to the health facilities for preventive, and then the private sector. What is it that ought to happen to improve that?
All right. So if you want to improve, you need to first know what's going wrong. What are the reasons that they're not reporting? And for a lot of these primary care facilities, either it's an issue of staffing. So there are no dedicated data officers who are reporting all the work that's been done in the particular facility to DHIS2. So it ends up being health workers who are doing the same, that meeting patients, they're treating patients, but also having to put away time aside to collect this data. So if we had entrenched data collection officers within the facility, then this would improve. And also right now, within primary care facilities, not all of them have direct access to the DHIS2 system. It's online, so it makes it easier. But many of them have to do paper forms and then now submit it to a sub-county data officer who then does the data entry to the ministry. And this brings about other issues as well, because now quality. And if you have very few data offices at the sub-county and many facilities, so what time does he end up finishing all the data entries before he has the next month's reports? And so those are the issues. And those actually are probably the reasons why we are missing out on a lot of data from the private sector. And there are also many other contextual factors. Our general data culture as people. So why should I collect data if I don't see it being fed back or informing anything that I am doing? And so that's one of the things. If I go to a facility, like, why should I be writing this? And I've not seen the ministry improve the state of health within my facility. And so it's important that also from the top down, we are able to show that we need this data. It has utility. And so that's where also our research comes in, is that from this data, we can make these different findings. So can we improve the overall system to ensure that we are getting more data so that we can make better decisions overall?
But if you look at any healthcare facility, it's like a data collecting hub. There is no way you are going to attend or go to any health facility without some information being recorded about you. It's not possible. The problem, if indeed there is a problem, is not that the data isn't available. It's always been available. There's a concept. It's called task shifting. Okay? A problem may arise because you have a system that you insist on putting into play, and yet that system may not serve the purpose for which it is intended. why must, for instance, someone who is trained in healthcare, a nurse, a clinical officer, doctor, why must they be the ones taking, for instance, data about your name, your age, do you need medical training to take that information, to find someone's height, their weight? Do you need medical training to do that? The answer is no, you don't. And yet, this is where perhaps the role of what you call the healthcare worker, the community healthcare worker comes in. Somebody who may not necessarily have the training of being a healthcare provider, but they have the fundamental trainings of understanding certain basics of healthcare work, which are not directly related to what we call healthcare treatment or provision of healthcare. See, now, when you do population work as you do, okay, do you also collect data in understanding some of the work within healthcare facilities that doesn't necessarily require profound healthcare training, which you don't need to go to Kenya Medical Training School for or the medical school for, and which, again, that's where the task shifting comes in, so that it can be farmed out or it can be given so that the burden of doing the details for what people were trained for is what they focus on.
Yeah, that's an important point. But within our particular department, we don't do this work. But within the program, there is work being done around understanding the infrastructural challenges and also the health worker challenges that are being faced. And so one of them is that why must it be the nurse who's doing the data collection as well as all the other things at the same time? But it also comes back to the challenge of often the result you get when you present this result, it's that resources are limited. So who is hiring these different people? And that's an unfortunate roadblock, because at the end, that's why we have shortages of doctors. That we have unemployed doctors who are at home but are not being hired. But we need these doctors. And when you go to counties, they're like, we don't have money to pay salaries. And so this is more of a systems issue. We recognize that this can be done by other people. But now it comes back to where the resources, who is giving the resources to fund these different aspects, and where do they place their priority. And so some of our work is also just to inform, these are the needs you have. These are the priorities this should be your top priority. But after you've given this to the ministry, it is their purview to decide what now goes into action.
You know, and that's what I was just looking at. When we talk about the importance, because the conversation here is the importance of this population health research and getting to collect the data and getting to see what the data is telling us. If from the very beginning, those, and I keep asking who's responsible, those in positions of authority do not see the importance of this data, whatever you're doing here is, you're only capturing information that has been brought to you, but the people who are in charge of ensuring that information is collected and fed into the system in the first place don't believe in the system. It sounds to me like they have a system in place just so that we can tick a box here. Do we have a DHIS? Yes, we actually have version 2, DHIS 2, okay? Tick the box, but there's no money in this thing, so forget about it. Let's focus on other things. How much are we buying, purchasing medicine and equipment and all? Does the ministry actually position data as central to its decision making, and not just data that has been brought in the form of a report, but data in itself, such that you can say that there actually is dedicated staff that looks at how we shall get this data coming up?
Yeah, so there's a specific department that focus on DHIS2 and improving the quality of the data. And so also when we are doing this work of just showing where the gaps and limitations are with the system, this was being fed back to them. And those are actually some of the actions towards improving the system. So it's not all hope is lost, it's that progress is happening, but albeit slowly. So these findings go back to them. It's like, these are the facilities that you need to look at. And for them, right now we do see that it's a priority. But in terms of progress, I cannot speak for their end. Okay. We give them the data, we give them the information, and we hope that we continue to see progress. But because we have seen a little bit of change together on the findings we already shared, then I have hope that we will continue to see the same going forward. Yeah.
Are there specific examples where you can say, so here is what our unit at KEMRI Wellcome Trust did. We went into a specific community because of certain interventions that were taking place or certain research that we were conducting, and we collected this data. And this is the quality of data that we have on this platform vis-a-vis the quality of data that's contained in the DHIS2 from the same community. And then you show what you're able to glean out of this data versus what you're able to glean out of the other.
Yes, but we didn't do a community, but we triangulated between survey data,
Right.
where people went into health facilities, visually confirmed someone has this given test. This facility provides this particular service, right? And so they did this around 2018. So we look at that data, and you say you have the test, you have the service. And so we look at the same facility on the reporting platform. Right? So this is a one-to-one comparison.
Yep.
The same facility on the reporting platform. At the same time that this survey was conducted, was there any submission of a report that you have conducted a test? Sometimes yes, sometimes no. And for tests that you expect in a lot of places, HIV, malaria, we found that actually they were in many facilities, but most of those facilities were not making reports.
They were not reporting.
Exactly. And so that means it's not a matter of facilities are not doing the work. As you said, this data is being collected, tests are being conducted, work is going on. It's just a matter of how can we improve the system to ensure that we are capturing that data.
Can I ask this question? Who within the health the health facilities is charged with entering this data in the DHIS? Who?
So it depends on the level of the facility. So, for example, as I said, in primary care facilities, they collect this data manually, and then now it's given to the sub-county health records information officer. And so the health records information officer is the one now who has access to that platform.
Who's responsible for sending this data to?
No,
The
that
sub-county.
yes.
The next person, yeah.
Who's responsible at that primary health facility?
I don't think I can speak to that actually. Yes. Yeah.
Because I think that's a question that
Yes,
is asking.
because
Are there dedicated officers who are expected to perform this function? Or is it, okay, so if this health facility, so anyone here will be calling you and asking you, wait, amjatuma report?
I'd expect that there is, but I can't speak with assurance. I can't talk to how the system itself is structured.
Okay.
Yeah.
You know, there's you see there's a gap clearly, because the burden of doing literally everything within, say, a very primary health facility is with a nurse.
Yep.
They do everything literally. There will be a problem, there will be a gap. This is the person who's taking the details of the patient. This is the person who's ensuring the patient receives care. And this is the same person you want to actually enter data. This one person, there will be a problem. You see, where am I going with what I'm saying? When we look at populations, and we're talking about now the patient population, what about the healthcare provider population? What they do, the tasks that they have, the inadequacy of numbers, the inadequacy of the diversity of people you need within that, because we have structures that have been there since antiquity, but with the increase in population and an increase in the demands for healthcare, have we met these needs with adequate population of healthcare workers to meet these needs at whatever level of health facilities that we're speaking of?
The simple answer to that is no. And that comes back to, if you want to improve your health system, it's not about just having enough drugs. It's having enough healthcare workers, having enough health facilities, having enough services that meet the needs of the population. And so all these elements need to improve at a similar rate to the needs of the populations that they serve. But unfortunately, especially with regards to healthcare workers, we've seen time and time again that they're overwhelmed and they're not enough. So I can categorically say no, that we are not yet meeting their needs with regards to human resources.
I'm going to ask a question that doesn't relate at all to what you do, but I have to ask it anyway, because it then boils down in my mind to how we train our healthcare providers. Do you think that those who write curriculums and those who train healthcare providers train them with the needs that we have currently in mind, because there's all this information that we have. Does it trickle down and percolate to the point where this information also influences what is taught? It's an unfair question. I am aware it's a completely unfair question. I know it isn't your docket, but I'm asking it because it's in my mind. And you see, if we collect all this information and the training of those who provide healthcare is the same, that gap will just widen. It's not going. We're not going to bridge this gap at any point in the near future.
It needs to match what we need.
Yes, it is, because it's information, and we so it's not that we don't know. We do know, but how then do we equip those who we are going to send out to be able to provide the services that we know are required, if the training doesn't match whatever we've seen as the needs that are there?
But if you look at it, well, I can't speak specifically to healthcare workers' curriculums, but more generally, if we look at the education system in general, are we able to actually create graduates and professionals that are meeting the current market?
That one, like
That's
the
a
question you
question
answered,
that
it's a simple answer. In many instances, no.
And so it works the same way for the healthcare sector.
Healthcare sector, unfortunately, is very fundamental just to our well-being. So it's not one of these ones where, for instance, I can't think of a profession that I can mention without sounding like I'm being biased and silly and I'm picking on them. But really, to update this process of training to meet the needs, it's not something that can be trifled with. But more specifically within the healthcare sector, even more specifically within the education sector. So, but if that gap then exists, then it means the very needs that we are seeking to meet or to mitigate against will never be mitigated against. Yes.
Yes, but so for our work within the program, we hope to there are different elements to it. We can look at first the health system, data systems, and how we can use data to inform decision making. And also there are other programs and other research that's ongoing to look at how to improve healthcare workers' welfare and also the training. So all these elements work together to feed the system. And so we might see progress much slower, but the work is there. We are looking at ways in which we can improve and inform how we improve our overall system at large.
No, we had a conversation with the Professor Edwin Baraza. He was sitting exactly where you're sitting, on that very same chair, and in front of that very same.
All factors were constant.
And there's something he mentioned that has been on my mind. It has even troubled my mind. Troubled, not in a bad way. It has got me thinking. He was talking about the universal healthcare system, and he gave the example of Rwanda, and how the thing that many people grapple with, they seem to have understood how to sort out, how to ensure that you look into primary healthcare, focus on that first with the universal healthcare system. Okay, now, if that were implemented through a process, whether it's through the NHI, whatever system you want to call it, would the data collection process that we were speaking of, that you people have, and that of the other groups that do research in other fields, would that provide the sort of platform that can coalesce all this information together so that you can no longer complain about not having a portal that has all this information in one place, so that the utilization of the collation and analysis that should lead to the utilization of that information is easier? If we were to extend our imagination a little bit, do you think such a possibility would be good? Or it could work?
And is this about having a data system that brings all that data together? But now that's what DHIS2 is.
No, it doesn't do it, because why I'm saying
It doesn't collect.
No, it doesn't. You see, let me explain what I'm saying. It's supposed to. In reality, it's supposed to. And to some degree, it does. Okay? But it's a question of whether that information is actually taken there. Now, if you have a system where, say, for instance, we're talking about NHIF, you have a system that the moment you present yourself, because you have that facility for that healthcare, the information that we're speaking of doesn't have to have that torturous process of being collected.
Oh, exactly. Yeah, that's so interoperability. We need systems that
Yes.
work together.
Yes.
So in essence,
Yes.
it's not that I have very many independent systems that have to work.
No.
Yes, and actually that would be the best bet.
Yes.
And particularly when you look at private healthcare facilities for which we're missing a lot of data,
Yep.
they do have their own medical record systems that are digital. But now the challenge has actually been that it doesn't link directly to what the HIS2 is. So that's an additional task to now work on data that they are collecting and also do the same for DHIS2. And that's actually one of the reasons why we miss a lot of data on
the private facility.
sector. But now that means that when we're talking about data and collecting data, it needs to be a collective process. Like we need to do it together. It's not that each person has their own way of collecting data. And that's the situation you see we have with data silos. Different funders are funding
Collecting
different
their own.
programs and they're collecting their own
Their
data.
own instead of
Right. And so I was given also an example of some health facility within a rural area where someone has a computer for USAID, he has a computer for DHIS2, has a computer for another funder, and has to enter data in all these different systems. And so really we should have one universal system that captures everything.
That
and I think that would,
harmonizes.
yes, that would go a long way in improving how we are able to monitor the whole health system.
Angela, you come again soon.
Definitely.
So we have a longer conversation on this.
All right.
Angela Moturi is an assistant research officer at the KEMRI Wellcome Trust Research Program. We've been talking about the population health research and its importance.
This is the Situation Room, the only way to start your day.